I am trying to support an awful lot of lung patients, and the same thing has been said every single year. Is anything to be done to research into it? We're getting more lung patients, but we feel that all the patients coming to me and say that they actually feel that they've forgotten that it's all about the other kind of nets, but lung patients feel that they're not being listened to, they're not getting research done, and is there more research going to be done about people who have lung nets?
Lung is a challenge in that regard, and it's a little bit, I don't know if it's political, but before Jerome Coffey took over, lung neuroendocrine tumours were put into a slightly different category. They were put into the category of thoracic or respiratory oncologists, as well as the surgeons who treat them. The vast majority of patients with lung neuroendocrine tumours or carcinoids have small ones that are resected, and a lot of them are what we call cured, okay, even though they need to be followed up. And this is one of the issues, because you do need to have follow-up. The surgeons, I feel, they need some help in this area, and sometimes also the general oncologists as well. We are open to taking on more and more lung patients, and from the European perspective, we've opened the door to lung as well, because we have found, just like you've mentioned or hinted at, that patients with these lung neuroendocrine tumours do fall in between two stools, because the surgeons who are treating the patients, they're very good technically and all the rest of it. They don't have a knowledge or a great depth of knowledge of the overall follow-up and the biology of this patient group as well. It's something we're trying to open up, and we have more and more patients coming to us in St. Vincent's anyhow with this. We have 2 cardiothoracic surgeons who are interested. We've got a couple of surgeons who are also coming to us from the Mater and different institutions and some private hospitals as well, and they're bringing their patients to us for an opinion. We're open to that. We'd like to do it in a politically correct way. I don't think there should be any fighting over ownership of this. The important thing is that the patients are seen, they're given the best opinion, and you know, if patients need additional treatment, we always put the patient back with a referring oncologist or the referring physician if that therapy is possible locally and regionally, let's say. So, and it's something I think that maybe Jerome and I could discuss and with the group as well. Jerome, would you have any comments on that, please?
Thank you, Dermot. That's a fundamental point for NETs, that there really aren't any boundaries anymore, and there shouldn't be any kind of obstacles between institutions in this country. So if patients need to be referred for an MDM discussion or for delivery of care, that should happen. I think this group has shown that it can be done. Looking back over the last 10 years, the Cancer Control Programme, all the changes that have happened have been a mixture of either investment or organisation. Investment is difficult at the moment, but organisation isn't, and there are 2 main types. One is cooperative and one is combative. And I think the Net Patient Network shows how cooperation leads to impact, leads to improvement in service care and delivery. And listening to the speakers this morning, it is clear that changes for the better have happened very significantly. The new scanner in Vincent's, the SPR in gastroenterology, all of that. Not every other patient group is organised to the point of achieving that in such a short time frame. The other point I'd make about the rare subgroups of the rare diseases would be that we have an excellent national cancer registry in this country, so we get 100% coverage of all cancer diagnoses, all the rare diagnoses. Harry Comer kind of developed it from nothing in the mid-90s to an institution that has got a huge reputation internationally. Now, he's retired and his successor has taken up office this year. So the Cancer Control Programme, we'll be working very closely with her. If there's a suspicion that a patient group is not getting a focus, or there is room for improvement in the service delivery, we can find out exactly how many cases diagnosed in each hospital and how they're being managed. And I think that's a mechanism we would use, say for lung nets if necessary, to make changes, to impose changes in hospitals if patients aren't being entered on the right pathway. On the research front, I really can't comment on that, and maybe that's one for a medical oncologist next year.